at lunchtime, you're welcome to go for a few laps with Dr. Wright. So our next speaker is Dr. Janet Stanford, who's a epidemiologist in the Public Health Science Division here at Fred Hutchinson and also at the University of Washington. And she truly is a world leader in understanding risk for both the development of prostate cancer, including environmental and genetic, as well as progression. So Janet's going to tell us about her work today. Janet.
Thank you, Pete, and good morning. That was a nice intro from Dr. Etzioni as well as Dr. Wright about some of the concepts that I want to share with you this morning. So some of the work we've been doing recently relates to the question of whether or not there is etiologic heterogeneity in prostate cancer. We've known this as a factor that's important in breast cancer for at least 30 years now, but only recently have we begun to look at prostate cancer. And when we talk about etiologic heterogeneity, well, etiology, as you know, is the causes of cancer, and these could be environmental, lifestyle, or your inherited genetic background, acting alone or in combination. Heterogeneous just means that things are different or distinct. Things are not like each other. So when I talk about the concept of etiologic heterogeneity, what this means is that there are different causes or different groups of risk factors that are responsible for the development of specific and unique subtypes of cancer. Now, at the time of diagnosis, about 95% of all prostate tumors are what we call adenocarcinomas. And up until recently, what we've considered these to be is a single etiologic, common etiologic factors responsible for these tumors that were thought to be representative of a single type of biological entity. But with more recent work from the molecular standpoint, we've been able to look under the hood, if you will, and see that these are not all the same. All these tumors are not created the same. And so now we can divide these up into unique molecular subtypes and look at whether there are specific risk factors that are associated with these distinct molecular subtypes of prostate cancer. And one of the particular subtypes that we've been interested in is what's called the TMPRSS2 ERG or T2E gene fusion prostate cancers. This T2E gene fusion is found in about 50% of prostate cancers. The TMPRSS2 gene actually is an androgen-regulated gene that's highly expressed in the prostate. ERG is an oncogene that codes for a transcription factor that's involved in the cell proliferation or drives cell division in the prostate. We know that this fusion occurs, it's thought to be primarily due to enhanced androgen signaling, but what happens with the androgen ramping up the activity of this oncogene is that there's really an increase in the growth of cancer cells in the prostate. So we were interested in whether or not these two types of prostate cancer, those with and without the fusion protein, might have different risk factor profiles. And to do this work, we took prostate cancer tumor tissue collected at the time of surgery and then used a technique called FISH to determine whether or not the tumor tissue had this fusion protein. And what you can see is that about 52% of patients in this group did have evidence of the fusion protein. Patients that had T2E positive tumors tended on average to be about 2 years younger. Let's see. 2 years younger at the time of diagnosis compared to patients that didn't have the fusion protein. In addition, the patients that had T2E positive tumors were more likely to be of European ancestry as opposed to African ancestry. The tumors in these patients that had the fusion positive evidence also tended to have lower Gleason scores, and the patients tended to have lower PSA levels at the time of diagnosis. Now, I want to provide you with 3 examples of why we think there is etiologic heterogeneity in prostate cancer based on looking at our first molecular marker, the T2E fusion status. And the first example has to do with obesity, and Dr. Wright has given a great intro to the effects of obesity on prostate in relationship to prostate cancer risk. And we know that compared to normal men, obese men have lower levels of circulating androgens, and androgens are very important as a driver for cell proliferation in the prostate. And so on this slide, what we've done is we've looked at quartiles of body mass index, which is a measure of body fat. And what we've broken down are the patients shown in the green bars that had T2E negative prostate tumors. Shown in the blue bars are those patients that had evidence of the T2E fusion genes. And compared to men who were normal weight, shown here with a relative risk of 1, where there's no association, what you can see is that there's a slight reduction in the risk of T2E negative prostate cancer in men that are obese. This is the 4th quartile compared to the 1st quartile of BMI. But what you can see for the T2E positive prostate cancers is that there's a significantly lower risk of developing fusion positive disease in men who are obese. And this slide just summarizes those numbers for you. For each of these groups of prostate cancer patients, those with T2E negative tumors and T2E positive tumors, to look at their risk of developing prostate cancer, we've compared them to a group of normal controls, and these are men from the same population without a history of prostate cancer and their distribution of body mass index. And what you can see is that for men who are obese, 4th quartile of the BMI versus the 1st quartile, there's an actual significant 34% reduction in their risk of developing fusion-positive prostate cancer. The second example I'd like to share with you has to do with aspirin use. We asked men about their aspirin use and whether it was low dose or the baby aspirin versus regular aspirin. It didn't really matter. And this is work that was led by Dr. Wright, working with my group. We know that aspirin reduces both inflammation as well as oxidative stress. Both of those things may actually be involved in both increasing cell proliferation, and that provides opportunities for there to be DNA damage and a lack of the ability of the machinery to appropriately repair the DNA damage. So we thought if we could reduce inflammation and oxidative stress, one might actually see fewer T2E fusion events. So shown on this slide is the relative risk of prostate cancer according to the duration of aspirin use. And what you see in the green bars is that there's no real pattern of risk for the T2E negative patients. However, when we looked at the T2E positive prostate cancer patients, you see this linear decline in the risk of developing T2E fusion positive disease based on increasing duration of regular aspirin use. Shown on this slide are the actual numbers, and in fact, it turns out that if you used aspirin on a regular basis for about 5 or more years, there's a significant, about 50% reduction in the risk of developing the fusion-positive type of prostate cancer. Now, the third example I want to share with you came out of some work that we were doing on profiling the same set of prostate cancer tumors genome-wide for changes in DNA methylation in those tumors. And what you can see on the left, under the green bars, each of these vertical lines represents a tumor from a patient that had T2E negative prostate cancer. Under the red bar here, each vertical line represents a patient whose tumor had the T2E fusion. And you can see that from an epigenetic standpoint, these tumors look very different in terms of their epigenetic profile. And one of the genes that was significantly differentially methylated that came out of this analysis is a calcium channel signaling gene called CACNA1D, where we had evidence that there were multiple sites in this gene that were hypomethylated in patients who had the T2E fusion positive prostate cancer compared to those that were T2E negative. We know that androgens are involved in calcium and mediate calcium signaling. We know that increased calcium signaling can lead to increases in cell proliferation. So we're very interested in this particular result because this gene codes for an L-type protein that is the target of calcium channel blocking drugs that are frequently given to patients for the control of high blood pressure. So we wondered if actually use of these medications might reduce the risk of T2E fusion positive prostate cancer. And again, you can see here in the green bars, compared to the men who didn't use these medications, men who did use the medications, there was no difference in the risk for developing T2E negative prostate cancer. However, the blue bars show that if you used calcium channel blocking agents, your risk of developing T2E fusion positive prostate cancer was dramatically reduced. And looking at the actual numbers, this resulted in about a 61% lower risk of T2E positive prostate cancer in men who were using these calcium channel blocking medications versus those that did not. Again, no relationship in terms of risk of the T2E negative type prostate cancer. So overall, based on these three examples, as well as a number of other very recently published papers, it's turning out that there's evolving evidence for etiologic heterogeneity in prostate cancer. We believe that this is an important step that's going to help us understand better the etiology of prostate cancer, because now we've had a challenge finding consistent risk factors based on environmental and lifestyle factors, and some of that inconsistency from study to study may be due to the fact that we've treated all these cancers as if they were the same, and now we know that they're not, and we can begin to look at risk factor profiles for the different molecular subtypes of the disease. In doing so, we hope that eventually we'll gain new insights on the causal pathways and novel mechanisms involved that could be translated into better ways to prevent prostate cancer in the future. Thank you.